back to DASy 2020. For our next session, we're going to talk about rare AV access related complications. Now I would like to introduce you our chair, Dr. Yan-Xu Ting from Taiwan and Dr. John Swinnon from Australia. As for our commentators, Dr. Benjamin Leon from Malaysia, Dr. Yang Zhijun from Taiwan, Dr. Sang Sob-yong from Korea, Dr. Tan Chie Suat from Singapore, Dr. Vira Suwang-Luang-Sari from Thailand, and Dr. Chen Wei-Hua from Taiwan.
Hello, welcome back again to this very special section, Rare AV Access Related Complication. This section, we have Dr. Swinnon as our chair, and then let's welcome Dr. Swinnon for opening of the section.
Hello, everyone. Hello from Sydney, Australia. I'll be giving the first talk on drug-eluting balloons.
Yeah, Dr. Swinnon, could you share your desktop so we can see your presentation? Okay, thank you. Yeah, we can see it. Yeah.
So the topic I've been asked to talk about is the increased mortality with drug-eluting balloons for peripheral arterial disease. Is it real, and does it affect hemodialysis patients? So the first thing I want to point out, now a lot of people in the audience will know this, but unfortunately, I think there's a lot of people out there who don't know this, and I keep hearing this at meetings and hear people say this. It's very important to emphasize to everyone that drug elution does not improve angioplasty results. I'll just say that again. Drug elution will not improve your angioplasty results. That is not what they're designed for. I often hear people say, I've got bad results, will drug elution help? No, it won't. Drug elution is designed to protect a good angioplasty result from future restenosis. In other words, if you achieve a good angioplasty result today, you can protect that from the vessel's healing response, NIH, in the coming 6 to 12 months by applying a drug-eluting balloon. However, if your angioplasty result today is not good, drug-eluting balloons will not improve that. If you have a bad angioplasty result today, regardless of whether you use a drug-eluting balloon or not, that will always be a bad result. So drug-eluting is purely designed to protect your good result from future stenosis. So it's very important that people use drug-elution for the right reasons. Now, as we all know, fistula stenosis is the biggest problem in hemodialysis access. In fact, I think it's the biggest problem in hemodialysis. It's the recurrent stenosis of the native fistula. Stopping restenosis with drug-eluting balloons is a breakthrough. We started using drug-eluting balloons in the native fistula in 2010, and drug-eluting balloons have revolutionized our practice. The way we do our work now and the way we run our service has changed dramatically as a result of drug elution. Now, in my view, there are 3 types of fistulas when it comes to stenosis. Some fistulas never develop a stenosis. You don't need to treat them. And I think that's about half of them. Some fistulas develop a single stenosis or an occasional stenosis, and that's another quarter. And then there's a group of patients between 20 and 25% of your patient load, and they develop multiple or recurrent stenosis. We call them the frequent flyers. And that's where drug-eluting balloons have made such a big difference. Drug elution works. There's no doubt about that. It's very well established in the coronary circuit. The cardiologists, with their enormous well-funded studies, have proven black on white that drug elution blocks restenosis in the coronary circuit. There's good evidence, good trials showing that drug elution works in the peripheral arterial circuit, and there is also good evidence now that drug elution works in the fistula circuit. Just a word of caution, when we're talking about drug elution, we're talking about paclitaxel. There are other drugs around like sirolimus, but mostly we're talking about paclitaxel. This is a multi-center randomized blinded controlled trial we did of drug elution in the fistula circuit with restenosis. Very important. These aren't de novo stenosis, this is restenosis. So between 2015 and 2017, we randomized 144 recurrent stenosis in the native fistula to receive either plain old balloon angioplasty or plain old balloon angioplasty with drug-eluting balloon. And our primary endpoint was late lumen loss. On the x-axis, you've got the diameter. On the y-axis, you've got the months of follow-up. And if you look up here, when you use the drug-eluting balloon, you lose 0.5 millimeter of diameter per month. When you use a plain balloon, you lose 1.7 millimeters per month, a dramatic difference. And that was statistically highly significant. We also looked at fistula volume flow. At 6 months, if you used a sham balloon, you lost 37 mils of flow per month. If you used a drug-eluting balloon, you lost less than 0.5 mil. Again, a dramatic difference over 6 months. And the same result at 12 months. But the most remarkable thing from our study was freedom from reintervention. So on the x-axis, you've got freedom from reintervention, 100% up there. And on the y-axis, you've got duration in months. So if you used a drug-eluting balloon, you maintained your patency and you had few reinterventions. If you used a plain old balloon, no drug elution, there was a much steeper decline in your patency. And this was statistically very significant. So the conclusion from our study was that in recurrent stenoses, the Medtronic balloon significantly reduced late lumen loss in treated stenosis of the fistula circuit. It significantly reduced the rate of decline of volume flow. And most importantly, it dramatically prolonged freedom from reintervention from a mean time of 10 months to 24 months. So if you treated a recurrent fistula stenosis with a plain balloon, you would be back in 10 months. If you treated it with a drug-eluting balloon, you would be back in 42 months, 4 times longer. However, there are 2 questions. Is drug elution safe and is drug elution cost effective? The first question, is drug elution safe? No one thought there was any problem with it until Konstantinos Katsanos in the American Heart Journal in 2018 published his meta-analysis of studies of drug-eluting balloons in the femoropopliteal segment. So this is paclitaxel in the femoropopliteal segment. And he showed that there was a doubling of late deaths at 1 to 2 years when you use drug elution. Everyone was stunned, amazed by this. And there were 2 questions. Is this true? And if it is true, what's the reason for it? So this is his original study. And of course, it caused panic in the drug-eluting world. And there have been many publications and studies since, but in fact, the situation has not got better. This is a study from 2019. It's another meta-analysis of randomized controlled trials of the femoropopliteal artery disease. So this is, again, paclitaxel in arteries. And their conclusions, drug-eluting balloon significantly increases freedom from reintervention. That works, we know that. But they also concluded the risk of 24-month all-cause mortality was increased. So it seems that Konstantinos' original conclusions may be correct. But there have been many subsequent publications and studies. The literature has become very dense and confusing on this. And most of it is about peripheral arterial disease. It's not about fistulas. Now, the American Food and Drug Administration, the FDA, weighed in on this, and in June 2019, they made an executive summary on paclitaxel-coated drug balloons and late mortality. And this is their conclusion. The FDA analysis of available data shows an increase in late mortality associated with paclitaxel devices for the treatment of femoral popliteal disease. They could not find causality. So it seems as if drug-eluting balloons are increasing late mortality in arterial disease. Their recommendations: continue diligent monitoring, inform patient consent about this risk, and only use the balloon when you think it's going to be really important to the patient. Ultimately, the jury is still out on the safety of drug-eluting balloons. So what about the risk-benefit of paclitaxel in the dialysis circuit? The first thing I want to point out is this. You would all agree with me that if you do a better angioplasty, you will get better fistula function. If you get better fistula function, you'll get better dialysis. If you get better dialysis, you get better patient health, and better patient health means they will live longer and better. Therefore, it's reasonable to assume that the dramatic effect that drug-eluting balloons have in the native fistula are increasing the quality and quantity of these patients' lives. So I think drug-eluting balloons are protecting our patients from death and morbidity. Now, what are the considerations of using drug-eluting balloons in the fistula circuit in view of this evidence in the arterial circuit? Well, here are the possibilities. One possibility is that the studies showing an increased mortality are wrong. That's possible. I used to think that. I'm not so sure anymore. The second possibility is that the studies are correct, but only apply to the arteries. They don't apply to the fistula. The third possibility is that studies are correct and they apply to the arteries and the fistula circuit, but the benefits of drug elution in the fistula circuit outweigh the risks. And the fourth possibility is that the studies are correct, it applies to the peripheral arteries and the fistula, and we shouldn't be using it because the risks outweigh the benefits. Now, I don't know where the truth lies, but I think it'll be somewhere there. Either the risk of drug-eluting balloon in the fistula circuit is not real, or even if it is real, I think the benefits of drug elution in the fistula circuit outweigh the risks. But that's my opinion. The FDA has made some comments on paclitaxel in the fistula circuit. First of all, they've stated that in all the trials so far of drug elution in the fistula circuit, there is no safety signal, and that includes our study. And the second thing they point out is that paclitaxel in the fistula circuit and paclitaxel in peripheral arterial disease are two different things. Dialysis patients have a much higher mortality than the rest of the population. Drug elution used in the fistula circuit, they're larger balloons, they're longer balloons, they're repeated balloons, delivering a much bigger dose to the patient, and the runoff organ is very different, of course. In the fistula circuit, the runoff organ is the lung. So when this evidence of increased mortality came out in 2018, our team at Westmead had a meeting with the nephrologists and dialysis specialists to decide what to do. And this was our meeting in 2018. And this was our proposal. Restrict drug-eluting balloons to frequent flyers. That's someone who's had more than 2 interventions to the circuit in 1 year or more than 3 interventions overall. Restrict drug elution to precious fistulas where there's few alternatives. We considered an age limit, and we've largely used that. We try not to use drug-eluting balloons in younger patients. And we created a special consent form explaining the situation to the patient. The last thing I'll quickly touch on is cost effectiveness. Now, I've done a back of the envelope calculation on the use of drug-eluting balloons in fistulas in recurrent stenoses in Australia. So the cost of a drug-eluting balloon in Australia is $1,000. the cost of a fistuloplasty is $5,000. Now, our study shows that in recurrent stenoses, we will reduce the reintervention from 10 months to 40 months, so increasing the time by 4 times. So if we have a frequent flyer and we do an angioplasty with a drug-eluting balloon, one intervention every 42 months, that'll cost us $5,000 plus $1,000 is $6,000 in 42 months. If we do a frequent flyer with an angioplasty and no drug-eluting balloon, we will be back 3 times in 42 months, and the cost will be $20,000. So in recurrent stenosis, I think drug-eluting balloons are cost-effective. In de novo stenosis, I'm not sure. And the cost-effectiveness will depend on the cost of the drug-eluting balloon, the cost of the plain old balloon angioplasty, and the chances of the stenosis recurring. So my conclusions in answering these questions are, paclitaxel is probably not safe in the peripheral arterial circuit. The evidence for increased late mortality is moderately strong. Secondly, it is unclear that this increased mortality risk applies to the dialysis circuit. There is no evidence currently that paclitaxel in the dialysis circuit increases mortality. Thirdly, in addition, there is good evidence that paclitaxel in the dialysis circuit protects patients from bad dialysis and hence mortality and morbidity. So I believe we should continue using paclitaxel in the dialysis circuit, but consider the risk-benefit in each patient. Thank you for your attention.
Okay, thank you, John. And your 42 months freedom for intervention is really high among other studies. So I think we have one question that from Dr. Yue, the next speaker. Actually, he's asking about the previous trial that showed by the Singapore. They do the sirolimus, DASy-Day, and in that trial, they do include patients with acute thrombosis. And we think that maybe that might have some effect on the outcome. So what's your opinion about that? In your study, did you include any thrombosis, AV access as well?
2 important points. Can you hear me?
Yes.
Yes. 2 important points. We did not include thrombosis in our study because thrombosis, there's many other factors that come into play, like clot and anticoagulation, which are very hard to control for. The thing I keep emphasizing about our study is that we did our study on recurrent stenosis. Remember, if you treat a de novo first-time fistula stenosis, the chance of that stenosis recurring is not that high. It's maybe around 20%. If you treat a recurrent stenosis, and a lot of the patients in our study had 5, 10, 15 previous angioplasties, that stenosis was certain to recur. So we did our study in that group of patients that would very quickly show whether this technique worked or not. And I think the reason our results are so good compared to other studies because it was directed exclusively at these frequent flyers.
Yeah, because of time, I think we move to the next speaker. The next speaker is from the China, Shanghai, Dr. Yue Jianing. He's also the winner of the challenging contest last year in the DASy. Today, he's going to talk with us about his patient tracking system in his referral center in China. Let's welcome Dr. Yue.
Hello everyone, I'm Dr. Jianing Yue, the vascular surgeon from Zhongshan Hospital in Shanghai. Firstly, I would like to appreciate the great efforts being made by the conference committee for making DASy 2020 to be held as scheduled in Taiwan in this very special time. And I will also thank DASy giving me this opportunity to share some of our preliminary work on this topic, in which we developed a patient tracking system to follow up the vascular access patient. Although there is still controversial, most guidelines still recommend a regular follow-up for the vascular access patients. Considering that the surgeons do not meet with the dialysis patients regularly, it is essential that they have an effective system to keep all their patients tracked. In the majority of hospitals here in China, the electronic medical record system is not designed for patient follow-up. I have to say that in most of the referral medical centers like Zhongshan Hospital, due to the huge numbers of patients, the heavy workload of our medical workers, and the high proportion of out-of-town patients, the follow-up work has been a well-recognized problem in Chinese medical system, not only for the dialysis access surgeons. So there is a rising demand for an efficacy follow-up method by using technology to track the patients. One of the most ideal design is a patient-initiated reporting system. The main idea here is that we think our patients, their family member, or even the dialysis nurse can regularly report the information to the surgical team. In fact, a lot of commercial companies have developed such apps. These apps can be easily found in the App Store. They are based on the fact that the information direction is from the patient to the doctors. They ignore the fact that the patients are not always that compliant. Nobody can make sure that the patient uploads their data on time. Here is an example from my colleague in Jinshan Hospital, Chongqing Medical University. They designed such a program. It was very innovative and well designed, considered a lot of details. The name of this program is called Tonglu Huhang in Chinese. The patient were asked to follow a WeChat service. The WeChat is the most popular social media app in China, but the communication is patient-initiated, so it is a one-way direction. Most of the patients even do not open this service anymore after several weeks or months after discharge. So the monthly active user rate is about 20 to 30%. For social media apps, such rate is not bad, similar with the Facebook, Twitter, or Instagram. But we still lose about 70% of patients, which is not acceptable for patient tracking system. So another solution is a provider-initiated tracking system. In this system, the clinician or our nurses regularly contact with the patients or their family members or the dialysis nurses actively to gather the information, and then they input this information into the database. The process seems to be getting complicated, but it can guarantee that the majority of the patients can be followed up without losing anyone. So we designed such an online patient tracking system. The clinician can just use it in its web page version in their computer browser, and the app can also be installed to the clinician's mobile device. You can also simply share the whole database with any medical workers in your team. But on the patient side, they do not need to install anything. In this slide, I would like to show you how this system works. Firstly, after each procedure for a new patient, you need to add a new record into this system, including the patient's cell phone number. And the system will automatically synchronize the patient's cell phone number with a Google account, and will be pushed automatically to our cell phone signed with this Google account. And then our nurses keep this cell phone only for the follow-up use. Also, we have a WeChat installed in this phone. WeChat have the access to the phone contact and can add the patients as our WeChat friend if they are a WeChat user. So you can see the whole system, the whole process is automatically. The only thing you need to do is to input the patient's information at the very first time. These are some examples that we use this system on the phone. You can see that we can input the procedure's detail on the mobile phone and contact with the patients on WeChat, or make phone calls directly from the contacts, or make phone calls from the database. In the next slides, please allow me to show you more detail on the database web page version in a 7-minute video. Hello. I'm here to introduce this patient tracking system, which is actually a friendly organized spreadsheet database hybrid, a little like the Microsoft Excel software, but it is a completely online system, and it is much more powerful than Excel. You can see the name of this database we have here is Zhongshan Hospital Vascular Access Working Group. We can see that the whole database is divided into 6 tables, the most important of which are the first 4 tables, the list of the patients, the new fistula or the new access, the fistula repair surgeries, and the follow-up results. And the patient's telephone number and their dialysis centers, we put them in the later 2 tables separately. The structure of this database is that the last 5 tables are all linked with the first one. When we open the repair surgery tables, for example, we can see all the surgeries we have performed are listed here, and they are actually linked to the first patient's list table. Let's go back to the first table, the patient list table. In each row, each row is for one patient. Actually, I mean each dialysis access for each patient in a single line. The table independently records the basic information of the patients, including the hospital ID, the dialysis centers, and the type of the current fistula, and the gender, age, risk factors, lifespan of the access, and the contact method. Okay, these 3 columns are the most important. The new fistula surgery, the repair surgeries, the follow-up results. It should be noted that each patient's fistula may receive repeated repairs or the follow-ups. So in the last 2 columns, we can see that many times we have multiple records with blue background token in a single field. Each record corresponds to a certain surgical or follow-up event. For example, let's look at this patient who established a fistula in her left forearm in March 2015. Let's open this records. Here we can see that we recorded the very detail of the surgery, including what kind of fistula, which artery, and which vein we used, and the anastomosis model. We close it. Just look at here, he had a PTA procedure in January 2017 because of the stenosis of the access, and another PTA procedure in August 2017 because of the access thrombosis. Let's open this record, and we can see that the details of the corresponding repair procedure were recorded, including the indication of the procedure, the method we used, the lesion location, how we treated, and the equipment we used, and so on. Actually, almost everything you want to record it, you can design this database to record them here. Let's close it. The difference between these 2 operations is that we can see a yellow mark here, which means that fistula is occluded. In other words, the loss of the patency. I think it's very important in the calculating the patency, in calculating the patency rate when you do some research work. So I designed this eye-catching symbol. Okay, then let's see here. We found that in January 2019, she had her access occluded again, but this time the patient, during we follow up, during we call her, we know that this time the patient refused the treatment of the access and established another new fistula in other hospital. So the original access was terminated. So we use a red marker here to show that the access was terminated, which means the loss of the secondary patency. Let's open this record. We can see that all kinds of possible follow-up situation can be well recorded here. Okay, we close it. Let's come to these 3 columns. I need to point out that these three columns are also very important because they are related to the regularity of the patient follow-up. The first column, this number is generated by the system automatically, refers to how many weeks have passed since the last operation or the follow-up events. So this number is increasing dynamically every week. The second column here is the number of the weeks that we design to follow up the patient. The system will compare these two numbers at any moments to remind the user which patients need a follow-up. If the number is 0, it means that the patient no longer needs to be followed up. Just like this one, we just reviewed whose follow-up has been closed, so we use the digital 0. And you can see this patient below. He is required to follow up every 12 weeks. Then it is now 10 weeks since the last events, which means the patient is still in the follow-up period, and we need to do nothing. And then look at this patient. We set the follow-up period at 8 weeks, but now it is already 9 weeks. The system will automatically remind you by such a red label, which means the follow-up is overdue. So every time when we log into this system, it will be very easy to find out which patient needs to be contacted for a follow-up. Okay, let's get a summary. The great things about this database is that it has very good customer experience, friendly user interface, and the powerful formula calculation function and the logic function, so that the surgeons or the researchers can design the whole database by themselves, and you can record whatever variable you want to record online and then share with your collaborators. Thank you. Okay, this system is still in its trial version, but I would like to show you some about how things are going on. Right now, nearly 200 accesses are being tracked in this system, and we only lost 12 cases, which means the lose-to-follow-up rate is 6%. Rough data show that the surveillance-driven reintervention rate is about 30%, but one of the problems is that most of the time when you try to call a patient, the answer you got from them are mostly the positive feedback. The patients are always too optimistic. The problem is that they are not good at figuring out the abnormal signs, and they are actually reluctant to come back to our vascular clinic if the dialysis is going well. So the emergency cases are still more than 50% in our center. Okay, let me get a summary. This patient tracking system provides effective service to both the clinicians as well as the dialysis patients. We consider it is an adherence-enhancing strategy with more than 95% follow-up rate. Although this system seems not to reduce the thrombosis events, which will be our next step to try to get the patient back to our surveillance clinic regularly. Thank you.
Okay, thank you, Dr. Yue, for this very interesting ape. I think everyone must have a lot of questions for that. For the time, we go to the next talk. Next talk will be presented by Dr. Remy Chen from Japan, and she's going to talk about the arm pain during hemodialysis. Is it shunt related? Let's welcome Dr. Chen.
Hi, ladies and gentlemen. Thank you for joining us today while the world is facing with coronavirus. I am Remy Chen, a nephrologist from Kami Fukuoka General Hospital in Saitama, Japan. My hospital is near Tokyo Metropolitan in here. Today, I would like to share some of my experience about arm pain during hemodialysis, whether it is related to vascular access and how to measure it in Japan. This is my declare of COI. No conflicts of interest associated with this presentation. Well, at first, this is one of my patients. She has complained strong pain only in winter since 3 years ago. It gets better naturally as it gets warmer. This is her arm. The blood flow is about 1,200 milliliters per minute, not a very large shunt. Symptoms worsen at these times, like high QB setting, high URF, high blood flow at cold days and at night. We and herself have tried that if we decrease QB setting, decrease remove rate, she will feel better. Because she thinks the pain is caused by vascular access, we consult her to outpatient department for vascular access in the university hospital, and they tried a VIVT for her like this. But it is a pity she got much worse after that. Then I tried to consult her to orthopedics, and we found she has cervical spondylosis and compression fracture from X-ray and MRI. But because she is afraid about the surgery, and the pain gets better naturally as it gets warmer every year, she rejects to continue orthopedics OPD for rehabilitation or surgery. Of course, I have already gave her vitamin B12, limaprodel Alpha-Dex, and NSAIDs for her to control her pain. Well, I guess all of us will encounter such cases on a daily basis. Then, what should we do? Next, I would like to talking about the percentage of vascular access in Japan. Almost 90% patients on HD are using AVF for their vascular access. I think this is a very high rate in the world. Last year, when I visited university hospitals in Chicago and in New York, they said we Japanese are working very hard. Vascular surgeons in the United States always give up immediately, and they have to use perm catheter. Arm pain not only during HD but also persists outside of dialysis. We generally believe that our pain during HD is caused by first cannulations, suction of vascular wall or venous valve, and due to poor blood flow, and of course blood return jet increase intravascular pressures, and pain from muscle or nerve. And the arm pain outside of dialysis is caused by vascular access occlusions, thrombus, infections, and pain of shunt aneurysm, and of course arterial steal syndrome, social syndrome, and maybe due to vascular access surgery itself. Then, of course, we can find troubles of cannulations when we cause pain during HD like this. And still syndrome like this. And precursor to immediate aneurysm rupture. You can see it's a little blue. And Sjöström syndrome, and the infections, swelling and reddish. Of course, we also must consider the differential disease like carpal tunnel syndrome, cervical spondylosis, pain from shoulder joint, oversensitive or autonomic or sensory nerves, vessel thrombosis beside VA. We always measure for the arm pain of our patients if it's due to vascular access occlusion or stenosis. We will consider vascular access intervention therapy. If we notice the infection signs, We will try to treat the infection of vascular access, maybe use antibiotics, or of course repair the vascular access by surgery. If the pain is from cannulation, we always use local anesthetics, cooling, or compresses. And if it's caused by aneurysm, Still syndrome, or carpal tunnel syndrome, we will consider the surgery. We also try painkillers, change puncture site, use drug improve blood flow, such like antiplatelet drugs, or use heat therapy, including infrared therapy. This is the flow chart for diagnose our pain. Again, we will observe whether it is only during HD or persistent pain or differential disease and consider a solution. Our medical staffs, including nurses and clinical engineers, all using vascular ultrasounds for care about the vascular access of our patients in Japan. Of course, we check the conditions, form, flow, and use ultrasound for guiding cannulation. The image on the left demonstrates a thrombus formed in the blood vessel. The right one is a blocked blood vessel. Blood flow is blocked. Even if these blood vessels can be punctured, sufficient blood flow cannot be drawn for dialysis treatment, and it may cause patients pain. Moreover, we cannot recognize such problems from physical find alone. We can use ultrasound to find the stenosis in their blood vessels like this and this, and to check if there is a precursor to immediate aneurysm rupture like this. In recent years in Japan, echo-guided puncture has become popular. The method uses an echo device to visualize blood vessels and needles like this. Of course, we are paid for using ultrasound in HD centers in Japan and using local anesthetics, analgesics, compresses, and antiplatelet drugs in Japan. As far as I know, this is one of the reasons why the ultrasound is not popular in Taiwan and popular in Japan. This is my presentation today. Thank you for your attention, and please feel free to contact me anytime in your convenient way.
Okay, thank you, Dr. Chen, for your very nice talk. I think we go to the last talk before we go into discussion by Dr. Zhang. I think the last talk is by Dr. Ye Hong from China. She's an interventional nephrologist from Nanjing. I think today she's unable to be online, but she has a piece of talk for us. It's for rare hemodialysis catheter-related complication. Let's welcome Dr. Ye.
Distinguished audience, ladies and gentlemen, good afternoon, Mr. Chairman. Thanks for having me here today. I'm Dr. Ye Hong from the Center for Kidney Disease, Second Affiliated Hospital of Nanjing Medical University. The circumstances have been tense lately in mainland China, so it's a real privilege to address this distinguished audience through video. Please allow me to devote myself to the topic of rare hemodialysis catheter-related complications. Thanks to the rapid growth of hemodialysis technology with the help of which patients' lives have been tremendously extended. As a result, vascular access plays an increasingly important role. The main types of hemodialysis accesses include AVF, AVG, and the CVC, of which our conceptions have been evolving in recent years. From the principles of AVF first and catheter last to the full right, namely right access for right patient at right time for the right reason. The management of vascular accesses should be integrated with the overall life expectancy planning of ESRD patients. Dobbs research shows that there are still over 20% of MHD patients receiving hemodialysis using central venous catheters as managed accesses. Catheter-related complications severely affect the usage of TCC, thus increasing the rates of hospitalization and fatality. Catheter-related complications include catheter dysfunction, infections, and central venous stenosis. Rare cases of complications include catheter misplacement, vein wall adhesion, vascular perforation caused hemothorax, pneumothorax, air embolism, arrhythmia, etc. These complications sometimes even endanger patients' lives. Here, I would like to share two rare cases of complication during catheter insertion in our center. The first case is catheter distal end misplacement. This was a 32-year-old female with the catheter dysfunction of right internal injugular vein, long-term for 8 months. A catheter was temporarily used for hemodialysis. Then ECAVF was created at upper right arm, but replaced 2 months later by a right IGV-TCC because of AVF maturity. Here, right upper extremity and the central veins was examined by contrast. The results are as follows: a severe stenosis in cephalic vein of the AVF at her right elbow, as well as stenosis in proximal of right brachiocephalic vein. During examination, we found a thick vein connecting the right atrium, which is actually the persistent left superior vena cava. Because of its thickness, we decided to insert a catheter through puncture from the external jugular vein. Guided by X-ray, the catheter was successfully inserted. However, after half an hour of hemodialysis, the patient began to complain of chest distress and palpitation with an ECG showing SVT. Her heart rate ascended to 150 to 180 beats per minute, and blood pressure drops. Suspension of ultrafiltration and blood infusion did not improve any symptoms. After termination of hemodialysis, her heart rate lowered to 100 beats per minute. Considering arrhythmia may be induced by the PRSVC catheter, we decided to remove it and created another access. Now, let's take a closer look at PRSVC. PRSVC is a common malformation in thorax. The reason for the formation of PSVC concerns the failure of left superior vena cava degradation in the stage of embryogenesis. PSVC is quite often related to arrhythmia. There remains controversy whether PSVC is suitable for catheter insertion. These literatures are recommended. In our opinion, PSVC catheter should be avoided unless no other vascular is accessible. Notably, before catheter insertion, anatomy of intrathoracic vessels should be carefully evaluated by imaging. The insertion should be guided by X-ray. In the process of catheter insertion and hemodialysis, ECG should be continuously monitored for early detection of arrhythmia. Once the arrhythmia induces disruption of hemodynamics, catheter insertion or hemodialysis should be halted and the catheter be removed immediately. Well, let's move on to the next case. Case 2 is about stub catheter occurred during catheter replacement. A 48-year-old female with hemodialysis history of 6 years had a TCC at her right IJV because of her poor peripheral vascular status. Before transfer to our center, insufficiency of catheter blood flow appeared recurrently during hemodialysis. Moreover, urokinase thrombolysis did not work. We decided to replace the TCC with a temporary catheter. Meanwhile, create a vascular access in her upper left arm. Considering the 6-year usage history and the patient's history of secondary hyperthyroidism, the catheter might have been tethered by fibrin sheath or thrombosed or adhered to the vessel wall. We chose to replace the catheter under the guidance of X-ray. After dividing the cuff, clipping up, detaching and removing the proximal segment of the catheter, we inserted a guide wire through its stem end to the right atrium to pull the stem out. However failed, we conducted a continuous ethnography and found EGV were bound by long fillings defects and the initial segment of SVC by annular calcification as shown in finger. After communication with the patient and her family, we chose to conduct endoluminal balloon dilatation to remove the catheter. A guide wire was inserted through the catheter to inferior vena cava. A high-pressure balloon from Boston or Boston Scientific with 5 mm in diameter and 40 mm in balloon length was guided by the wire to the interior of the catheter. The balloon dilated from the catheter interior and the distal tip respectively with the same pressure of 20 atm. After 3 times of inflation, the catheter became loose enough to be removed. Risk factors for stuck catheter include cumulative injury time, insertion site, recurrent catheter infections, venous internal injury, material or catheter damage, implantation, history of standing or placement, as well as vascular calcification, etc. Affiliated hospitals of the University of Toronto removed 2,048 permanent catheters in 10 years with only 19 cases of stuck catheter, suggesting that the incidence rate is comparatively low. Fibrin sheath in the earliest stage forms and appears after 24 hours after catheter placement. There are also few cases reporting calcification associated with the formation of fibrin sheath. There also have been few literature shows how to remove tethered catheter. Most conducted thoracotomy or bari-restore catheter subcutaneously. Hong et al. Reported for the first time in 2011 on method of removing tethered catheter by endoluminal balloon dilatation, with which catheter dilates along with balloon, causing the fibrin sheath that tether the catheter to relieve. Thus, catheter can be removed successfully. Such method is simple but safe and effective. Another method is utilizing laser shift to relieve fibrin shift. In summary, these rare catheter-related complications not only cause access dysfunctions, but also induce more fatal complications. Therefore, precautionary measures should be taken proactively. Before the operation, medical history and physical examination should be carefully completed. Angiography is helpful in understanding the vascular situation. Puncture under the guide of the ultrasound is a wise choice. Remember, keep the puncture needle visible. Hidoki recommends the use of imaging-guided catheter insertion to achieve a higher successful rate. That's all for my speech. Thanks very much for your time.
Okay, thank you, Dr. Ye, for a very interesting dealing with the complication of the dialysis catheter. Before I hand over to John, there's one question from our YouTube viewer. They will direct the question to Dr. Chen. The question is that there's a patient who complained of upper arm pain after 1 to 2 hours during the hemodialysis. How do you explain this phenomenon and how do you manage to treat this problem? Dr. Chen? Dr. Chen, you still online?
Perhaps I could speak to that question.
Thank you for the question. I think this is a very, very popular situation on our daily basis. Yes, including the case I shared in my slide, we always many patients always complain about the arm pain, especially upper arm pain, and in the later of the dialysis. I think most of them is over removal fluid, and is caused about the return jet increasing intravascular pressure. So at that time, if you decrease your setting of QB or stop stop removing fluid for a moment, sometimes they will be better. And of course, you have, if they don't, you have to consider if they have any stenosis in their maybe cephalic arch or subclavian artery. I mean the proximal vessel stenosis or something problem.
John, could you comment on this?
Yeah. Can you hear me, folks?
Yes. Yes, very clear.
Yeah. Yeah, I'm actually very interested that the organizer of the meeting put arm pain with dialysis amongst the rare complications of dialysis. I think it's one of the commonest things we have to deal with. The number of patients on dialysis who complain of this pain or that pain or pain often or pain occasionally, I think it's a rule rather than an exception. I certainly wouldn't call it rare. I agree with Remy Chen's comments on dialysis flow. I broadly speaking divide arm pain and dialysis into two categories. So there's a lot of it. Most patients have it to a greater or lesser extent. The first category is identify the serious and correctable problems. And as far as I'm concerned, there are three. One is steel, the other one is carpal tunnel, and the third is cervical nerve root compression. And group of patients you've got to be particularly worried about are the diabetics, because they are likely to get steel, and they're also much more likely to get carpal tunnel. So if I get a patient with a fistula who complains of arm pain, and I think it could be their neck, carpal tunnel or steel, I get a CT of their neck, I get finger plethysmography to measure the pressure in the fingers on both hands, and I get nerve conduction studies. Trying to work it out clinically is almost impossible because these diabetics are full of nerve pains and neuropathies and stuff like that. So you get finger plethysmography, and that'll tell you pretty much black on white, is this steel or not. You get nerve conduction studies, and they will identify, is it carpal tunnel, is it further up, or is it in the neck, and you get a CT neck. So those are the three serious, identifiable, correctable arm pain problems. All the rest, I don't know if there's much you can do about it. I don't know, what do you think, Remy?
Well, I completely agree your opinion, and I think we have a problem that it's because when a patient has arm pain, they always have multiple causes. Not only one reason, but maybe many reasons. Like the case I shared, I think her problem is first overflow, and the second is the return jet because of her central vein stenosis, and of course cervical spondylosis. So if you want to completely resolve these, you have to do many approach for your patient.
Lou, you've got something to say. Can we get Lou on the line, please? Can't hear him.
Can you hear me now?
Yes.
Yeah.
Yes, I like the presentation by Dr. Chen, and I completely agree with the Swinan on what he said about the causes of this hand pain. But I must add, one of the common causes actually, frozen shoulder, or maybe osteoarthritis of the shoulder. Because you imagine that you have to put your arm there for 4 hours, not moving. So I think that can cause substantial pain. But very interestingly, many of these patients have this pain towards the last hour of dialysis.
Oh, yeah.
Strangely, it's always at the needle site. So
Yes,
it's very common.
Yeah.
So I think it has to do with some flow phenomena and also involving the nerve around it. And so for patients like this, what I normally do is I will then mark out other sites for them to cannulate. And with that, they often improve. So I think this is something I think we need to study further. It's interesting, like John says, it's very common. And sometimes we have no easy solution.
Yes. Okay, I guess I'm not be mute. Yes, of course, if the pain is focused in the puncture site, we will try to maybe remove the needle or change the needle position. And I think in Japan we have one very special situation is because we use the soft plastic needle over than 90%. So our needle is soft. So Of course, it still be it will be hurt your vessel, but I think that is much better than using a metal needle.
Okay.
Because if you yes, because patient will move their arm during the dialysis, and of course, if they do not move, just tension their arm, they will feel pain. Yeah, so the soft needle, if even you move your arm, the needle will not change the position.
I have one question from Dr. Yue. Is that for your platform? I think, is it possible for the patient to enter the event by themselves, because not all the patients come back to the same site for intervention sometimes. So is that possible that the patient do this event by themselves on their calendar, and you can sync with your app? Oh, sorry. I thought, okay. I just, okay. Sorry, the Dr. Yue is just offline, sorry. So, okay. Yeah, maybe we'll ask this question. Any other question from the panel? Because we have only 5 more minutes for this section. Ben?
Yeah, hi. Can you hear me?
Yeah, very clear.
Yeah, it's a question to John. Sorry, I was a bit late joining the talk just now. Was pretty busy with work. COVID-19 have just landed in my state for 3 days. I'm not sure in your study, is there any patient with central venous problem as well? Are they part of the patients in your study? And if not, what is your opinion about the usage of DEB for central venous occlusion? Because their recurrence rate will be a lot higher compared to the normal fistula.
John, can you hear the question?
Yeah, thanks for that question. The follow-up in our study was with ultrasound. So we excluded central veins because you can't actually see the central vein with ultrasound. Certainly, central venous stenosis is recurrence is the rule rather than the exception. Our study didn't look at that, but we certainly used drug-eluting balloons a lot in central veins. One of the early problems was that originally the drug-eluting balloons only went up to 7 millimeters, whereas most of the central veins are much bigger than that. So what we did before the bigger balloons were available is we would drug-elute before doing the angioplasty. So we would deliver the drug to the vessel and then do the angioplasty with bigger balloons. And although that's not the instructions for use, whether you put the drug in the vessel at the start or the end, I don't think makes any difference. You're just trying to block those healing cells from narrowing it down again. And certainly anecdotally, drug elution works in the central veins as well. It doesn't stop restenosis, but it delays it. I think a study should be done because there's plenty of central vein stenosis around, looking at that using bigger balloons. But if you look at the literature and if you look at the theory behind drug elution, it works. It works everywhere in all the vessels. You're poisoning the healing cells with paclitaxel, and it delays the restenosis. How big that clinical effect is, how cost-effective that clinical effect is debatable. But I think it pretty much works all the time. One of the problems that I try to emphasize in my talk is that there's a lot of people out there who use drug-eluting balloons to improve their angioplasty results, and it will not do that. If you don't achieve a good angioplasty result, putting a drug-eluting balloon doesn't make any difference. And I think there's a lot of misunderstanding about that. What do you think?
Yeah, I think so. I think so too. No, like talking about drug elution for central vein, I've not done a lot of cases due to cost issue, but it is true that from those patients that I've done, it seems that they show pretty good result. No, the recurrence rate is a lot longer compared to a normal POBA. In our country, we're lucky to have one product that is that has drug on it for big balloons, 12 to 16 mm, I think. But the problem is that their pressure is very low. So what I normally do is that I will buy it with a 12 or 14 mm balloon. Then I'll use one size bigger drug eluting balloon to apply on it after that, and they show pretty good result. Yeah. But I agree that DEB is not the way to go to overcome a bad POBA. I totally agree.
One of the other things that I emphasize about drug elution, we've been using this for at least 10 years in the fistula circuit, is that when you place your balloon and, you want to avoid geographical miss, you need to apply your drug elution to every part of the vessel you've injured. If you injure angioplasty, stent the vessel, you injure it, you provoke a response. So anything you touch or injure during your procedure, you've got to drug elute afterwards, which means you've got to use a drug eluting balloon that's bigger and longer than everything you touched. And that's why people talk about geographic misses, where they do a 7 centimeter angioplasty and only drug elute 3 centimeters of it. And so we always use longer balloons. And when you deploy these longer balloons, always bias your deployment upstream. If you deploy the balloon a bit upstream, the drug will be released into the stagnant vessel and penetrate the wall and have an effect. If you bias your balloon downstream towards the heart, any drug that's released past the lesion will go systemic and give you no benefit. But it's very important to drug elute everything that you touch.
Yeah, John, regarding your good angioplasty, what if the vessel still dissected after you prolong angioplasty? Do you do DCB for that? Or if the vessel require very severely, even you do multiple or prolonged angioplasty, do you do DCB for that?
Drug elution is not going to solve that. So at the time, you've got to get a good result. So either you've got to rupture it or put in an uncovered stent or use a high pressure balloon. Now, even if you get a bad result, say that you wanted to get 6 millimeters and you only managed to get 4 millimeters with everything you've done. Now, maybe you should still drug elute that, because if you don't, that 4 millimeters is going to go to 2 millimeters very quickly. Whereas if you drug elute, it's not a great result, but at least it'll last longer. But you've got to separate in your head that the drug elution doesn't improve the result, it just makes it persist for longer. But I would emphasize, really get that thing looking absolutely the way you want it before you drug elute, because it's a different purpose.
Yeah, okay, thank you. I saw that Dr. Yue is online now, right, Dr. Yue? Yeah, the question for you is that in your app, can the patient, input their data like the calendar, or can they just do the event by themselves, so you can pick up their, information from the web base, or you always need to, from your side to document all the event?
Oh, thank you for the question. So my internet here is not very stable, so I changed to my phone. Actually, the patient do not allowed to do this because we want to keep our data very clear and reliable. So we cannot let the patient to input this data by themselves. Even we cannot let them to arrange their follow-up data because regularly, usually they are not that compliant, and they even don't know what time is the best time for their to their next follow-up. And so right now, I will do this. Depends on, according to every time I finish a certain procedure, I will give them a very specific follow-up interval time, and then input to the database just after the procedure. and the system and this system will automatically remind me for that follow-up time.
Yeah, thank you. I think we got 5 more minutes here. I saw Dr. Tan's online. Dr. Tan, there's a question from you from the audience. From your previous talk about the study using the sirolimus DCB, the audience asking about if you do that in the acute thrombosis case, do you worry about residual thrombus that may cause some effect on your outcome? Or it's not, the main, not the main, only a little part of the patient does acute thrombosis in your study group?
So to qualify for the study, we need to be able to clear the entire circuit of all the thrombus. So that's an entry criteria. In the informed consent is taken at the point of before the procedure, and only if they are able to clear all the residual thrombus with successful treatment of the graft junction with conventional treatment, then the patient will go on to receive a sirolimus coated balloon at the graft junction. The concern is, of course, is that number one, residual thrombus tend to propagate thrombus, and so that will confound the result. And number two, residual thrombus at the graft junction will impede the transfer of drugs from the drug-coated balloon into the native vessels. And therefore, there's these 2 criteria that we actually set up to prevent that from happening. And in the ideal world setting where you can get rid of all the residual thrombus and have good angiographical outcome, before you apply the sirolimus coated balloon, you're going to get excellent results. And as shown in the talk, there are actually patients who go up to 1 year intervention-free period with treatment with sirolimus coated balloon. And that is something that we do not see with plateletaxia, which is something we are still trying to figure out what is the underlying reason for the difference that we see, because both agents are actually drug-coated balloon. I guess the other property that sirolimus coated balloon has is maybe it has some anti-inflammatory property, unlike plateletaxia, and maybe that would be advantageous in such situation. So we are actually going to run a randomized controlled trial to on a larger scale to actually test out our hypothesis to see if sirolimus coated balloon will be effective in arteriovenous fistula instead of a thrombosed graft in our next series of studies.
I think we have 4 more minutes. So any question from panel or John? Yeah.
For the year.
Yeah, Dr. Vera, you have a question?
Can you hear me?
Yes. Yes.
I have a simple question. I have a mini case with AVG thrombosis or stenosis. I have a question to Johnson or other panel. What is your suggestion? We should treat with the plain balloon, DCB, band stent, or copper stent for venous side of anastomosis of the AV graft.
I won't answer that question. We don't use grafts at all in our practice. So we've got 0 grafts in our practice, so I don't see that problem. So it might be appropriate for someone who has got grafts in their practice to answer that. Casey?
Yeah, your question is, do we use the stent graft for the outflow junction?
My question is, what is your recommend for the treatment of the AV graft stenosis at the venous side? You recommend COBA or band stent or copper stent or DCB? What do you think about DCB for venous anastomosis of AV graft when compared with COBA?
Well, as I say, we don't use grafts, so I can't answer that question. But I'm sure that drug elution would delay restenosis. But is there someone on the panel who has grafts in their practice and can answer that?
Yeah, I use, any other panel want to answer this question? Or I answer part of the question. Actually, we use the Viabond or other stent graft for this part if the patient suffer from repeated occlusion or stent dysfunction in 3 months. And I think you know about the data from the large trial that shows that actually it's much better than the PTA. So, but we don't have a lot of experience like John using for the DCB for that part. But I think for the study that the Dr. Tan just mentioned, I think it's promising. But I think the patient selection is very important. Whether you do it in the acute space, or you may delay to sometimes after you do the primary thrombectomy, or maybe you want to do it at the same time, because we are afraid about the residual thrombus that might have poor effect on the outcome. Yeah. So any other panel want to answer this question? Jackie, can you comment on this?
Just my personal opinion, I still think that if we can put no stent into the system, we can leave the stent as the more later on strategy. Because I feel that in-stent restenosis is actually quite a difficult condition to manage. So I guess I'll be very much seeing how much mechanical recoil is over the graft vein anastomosis, and really after the procedure, the stenosis recoil situation is bad or not. If the recoil situation is still bad, then I think we definitely need some mechanical scaphoid to help the situation. But if not, then I will more considering to give a drug platform to treat the condition first. Whether it's at the same procedure, you try to clear as much as the drug and clear as much as the thrombus and then provide the drug, or you come back in another setting, I think very much depend on patient's acceptance and also your system. Yeah, thank you.
Finally, John, can you close the section for us, because time's up.
I'd like to thank the organisers of the meeting for allowing me to take part in this, and I want to congratulate you on running this meeting in the presence of the coronavirus. I suspect that there's a lot of hospital administrators all over the world, when the coronavirus is gone and doctors say we want to travel again at the expense of the hospital, they'll say, no, guys, you stay at home and do telemedicine like they did in Taiwan. It'll be much cheaper for everyone. So I think this may produce a long-lasting change. Thank you.
Okay, thank you. Yeah, we close this section.